Guillain-Barre Syndrome. Dum, dum, dum. So I have a patient that has Guillain-Barre Syndrome, so I thought I'd make a video about it, because we didn't learn about it in school. So what is it? It's a demyelinating neuropathy characterized by ascending weakness. Pathophys, immune-mediated, so it's an immune response. So antibodies made by your body cross-react with gangliosides and glycolipids, and basically attack myelin sheaths on the axon. There's two types of Guillain-Barre. There's actually more, but I'm only going to talk about two. There's ADIP. I'm going to read this one because it's a long word. Acute inflammatory polyradiculoneuropathy. And then the other type is AMAN, acute motor axonal neuropathy. And they differ by how the myelin sheath is destroyed. So with ADIP, it's destroyed via macrophages. Nom 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 nom. So complement system is activated, blah blah blah, macrophages. In a man, IgG is what's attacking the myelin sheath. Etiology? Nobody really knows, but what we do know, it is what's the word? Whatever. It is preceded by an infection, usually. So usually a GI infection or a respiratory infection. So one of the infections, specifically Campylobacter jejuni, has a capsule around the bug, and the capsule has similar antigens as the ones that are on nerve cells. So antibodies are formed against the Campylobacter, but once the Campylobacter's gone, they start attacking peripheral nerve cells because the antigens are so similar. This is also seen, that's more GI, whereas CMV, EBV, mycoplasma, pneumoniae are more respiratory infections. They both have that capsule with the antigens on it that are similar. HIV is also another one. Presentation, so how do we know? So usually about 3 weeks after they're sick, they start feeling paresthesia. Did I say that right? Paresthesia in their fingers and toes, their hands and their feet. And then it progressively goes up. So toes to nose. So it's ascending weakness. Ascending weakness. It's also symmetrical or bilateral. So both sides are equally weak, which is important. It also depends on which nerves are attacked, because if it's in your cranial nerves, for example, you might experience dysphagia, diplopia, dysarthria, etc., pupillary disturbances, as well as it could affect autonomic nerves, so you could have tachy or bradycardia, you could have paroxysmal hypertension or orthostatic hypertension, facial flushing, all the autonomic things like urinary retention. And also it's painful. Your nerves are getting attacked, so ouch. Also, it's important to note that if it progresses to the respiratory muscles, you need to be intubated and in the ICU because you can't breathe. So, what's the treatment? There's two different treatment options. You can do plasmapheresis or IVIG. Not both, one or the other. So my patient is a Jehovah's Witness, so no blood products, human blood products, so IVIG is out. So plasma exchange or plasmapheresis is the option. Also, it's important to note, since they are in pain, they'll need analgesics. NSAIDs are what is preferred, such as indomethacin or naproxen and ibuprofen, as well as anticonvulsants such as gabapentin and carbamazepine, because it's nerve pain and opioids aren't going to cover that. You can also use tricyclic antidepressants like amitriptyline to help with pain. So IVIG or plasma exchange, and then analgesics. and that is GBS. Thanks.